Hello, everyone. Welcome to the Dr. Sophia ObGyn Podcast. I'm an ObGyn practicing for over 15 years in my native New York City, and I love to help women learn about their bodies, empower them, and embrace themselves. On this podcast, we talk openly and with heart about all things affecting women, from pregnancy, menopause, periods, sexual health, fertility, and so much more. Disclaimer: this is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Hello, everyone, and welcome to the Dr. Sophia ObGyn Podcast. I am so excited for today's episode because we get to talk to Touseef Mirza.
Oui, c'est moi. Touseef is me. When I have an introduction like that, I feel I need to say something in French.
Ah, okay. C'est bon.
C'est bon, c'est bon. Yeah,
bon.
for those of you who don't know, I grew up actually in Quebec, near Montreal, in Canada. So that's why the French comes out. It rarely comes out, but it does come out.
Well, I like it. I like it when it comes out.
Yeah.
Yeah,
Yes.
I do.
Very good.
So, of course, we are here with Touseef, my fave, my co-host, and my friend, and we get to talk to her about her menopause journey.
And HRT.
And her journey on HRT.
Yes. So I am opening myself yet again. Sharing with all of you my personal experience. And that's what I tell Sophia. I'm just like, at this point in my life, like, who the hell cares? Like, we should just be sharing everything. I got nothing to hide. This is actually the fourth installment of this series that is around Touseef on HRT. So for those of you who don't know, who are just like joining us recently, welcome, number one. We had basically my journey because I'm 54 now, and I started to be in menopause around 51, which is usually, that's the average age.
Average age.
Okay, so I'm average. That's what that means. And I obviously, as you know, I'm a very good friends with Sophia, and she also turns out to be my ObGyn, which is a fabulous thing. She knows me inside and out, the whole
Literally.
Picture. There's nobody who's known me like you. Actually, now that I think about it, all my emotions, all my intellectuality, and also all my uterus.
And your insides.
And my vagina and my breasts. I mean, everything. It's true. Nobody has known me more than you.
Very well. I accept. Thank you for the privilege of being able to care for you.
When I started to be in menopause, I started to talk to Sophia about where I was at, and she was telling me, well, maybe do you want to go on HRT? So we decided, why not just share this with everybody, because we have a podcast. So this can hopefully help other women as well going through this, and also just learning about what is menopause and what are the different intricacies and what are different ways that we address it. So can you just tell everybody what is menopause first before we start digging in?
Menopause, the complete cessation of a woman's period. We consider a woman has gone through menopause when she's had 12 consecutive months of no period. Average age of menopause is 51, but there's a whole time frame before we get to menopause called perimenopause, or the transition to getting to menopause. That can last anywhere from 5-10 years before you actually get to that last period.
And when we talk about the indicators of perimenopause, menopause, we're talking about hormones, and those hormones are?
We're talking about estrogen, we're talking about progesterone, we're talking about testosterone. But honestly, when we're talking about menopause, we really should be speaking about so much more of a full scope picture, because it affects so much more of the body. It's not just whether or not you have your period. So many different hormones actually change in the body as you're going through this transition, as you're in perimenopause. It's the reason why women for the first time may have high cholesterol. It's the reason why women for the first time may have a diagnosis of diabetes. It's the first time that they get a diagnosis of a mental health disorder. It's like there's so many things in that time frame. And there are so many other organ systems and hormones that are affected during that transition time and in menopause itself. We really are talking about the key ones generated from your ovaries.
And when you arrive in menopause and you have no more period, it basically means that those hormones basically drop.
They've come to a level where they're no longer acting on the uterus, let's say, the way that they once did. But remember, estrogen had 400 functions. 400 functions it has in the body.
Not just at the level of the
Not
uterus
just at the level of
or
the uterus
ovaries.
or ovaries. Yes, the estrogen is working on your skin. Estrogen is working on your bones. Estrogen is working on your brain. Estrogen is working on your breast. Estrogen is working on your heart. So estrogen is doing a lot. A lot of parts of the body have receptors for estrogen.
To do its thing.
To do its thing, like whether it's how it protects the heart, whether it's how it protects the brain, how it affects your mood, how it affects cognition. So there's so many other ways in which estrogen is functioning in the body other than your period.
So we've done 3 episodes already for Touseef's experience on HRT. The first one, if you want to go check it out, it's episode 12. And this is literally, I'm not on HRT yet, and I'm kind of challenging Sophia on a couple of things on the podcast going, do I really need it? Like, my body, yes, there's some kinks with it, but, why should I go on it? And, what are the pros? Because I'm, in general, as a person, I don't like to take medication unless it's absolutely needed. So I was just like, well, it's not like it's a disease. Why would I get on it? So that was all that conversation. And then we had the second installment, which was episode 28, which was reading my labs. So we at least got to that step. I was like, fine. I'll go get the blood test. We'll figure out where my hormones are. And then I can ask you tons of questions because I'm a nerd. And then we can see where we go from there. Mm-hmm. And then finally, after that episode, I decided to go on HRT. And I can explain a little bit more about that. And then episode 42 was my experience on HRT after being on it on 6 months. And I'll just recap real quick for that. So I finally decided to go on HRT based on different reasons. So there was one part where I was having a couple of symptoms that I just thought was related to old age. So I was just like, c'est la vie. I guess, in your 50s, that's what happens. And Sophia was like,
girl, no, no,
no. And I was like, really? Can really? So one of them was, for example, what I've come to understand is brain fog, which I thought I was just slightly like not being sharp anymore as I used to. And I've always been pretty sharp thinker. And then all of a sudden I was kind of slightly in a haze and it would require me more to concentrate. It was really annoying. Really
now.
Really annoying because I've got a lot of stuff to do, which I'm sure many people do. And so you're just like, I've slept 8 hours. I've had a meal. I took a walk outside. Like, what else do I freaking need to do to be sharp? I've done all the things.
Right.
And it's still.
You were having brain fog.
I was having brain fog. So that was one thing. And the second thing was, I figured like an old car, you get kind of rusted. And so my joints were a little squeaky here and there. There were a little bit of pain here, a little bit of pain there. And then also from a more medical history perspective, obviously Sophia knows everything about my life. My father, unfortunately, passed away due to complications following Alzheimer's. So there have been some issues with brain health in the family.
Right.
And my mom does have a few stents. So she has some cardiovascular issues. From a cardiovascular perspective, I was less concerned because I'm pretty healthy. But, the Alzheimer thing is just like.
It really hit. I think that was definitely one of the things that you were like, Alzheimer's. I didn't see the link, or you didn't see the link. And then we talked more about it.
Can you talk a little bit more about that?
Yeah, the concept is that, remember, we just talked about the fact that estrogen has so many functions and has many, many functions in the brain. And one of the things it does is decreases inflammation, actually. And so it does have a cognitive link. Like at the end of the day, more women will develop Alzheimer's, and they develop it after menopause. And so it's important to recognize some of those connections. And it's not to say that somehow, oh, we're going to just treat Alzheimer's because we've now gone on HRT. That is not what I'm not trying to equate those two things at all. However, in someone who has some type of predisposition or what have you, then I think adding or continuing, let's just put it that way, and someone like you who's very early in her menopause and continuing your body's use of estrogen in a healthy way, I think in the long run will help to decrease your risk of developing Alzheimer's.
And it's not like I think I'm going to get Alzheimer's, but I obviously want all the help that I can get in order to not have Alzheimer's, especially if I know that my dad had it. And I've been next to him for 8 years going through that experience. So that part, it's true that did play a lot for me, where I was just like, okay. So, and then I was like, okay, but then what are the side effects? And, am I going to is there anything that's going to affect me negatively? Because in my mind, I equate taking something every day, that's something that is prescribed as medicine. So something is wrong with me. Right. But I went back and listened to the last podcast we did, and I'm going to bring this back. It was the notion of, I think we need to change what estrogen and actually call it vitamin estrogen and vitamin progesterone, because you're not taking it because something is wrong. You're taking it because that is part of normal functionality of your body, like calcium, like magnesium. And I think that switch for me took a long time, but I finally understood, okay, it's actually biomimicking the estrogen, the level of estrogen that usually has. It's not like a completely, like, I guess, a lesser synthetic form or something.
I guess the most important part of it, or to understand, is we're simply trying to kind of, maintain you on where your body was before you were in menopause, right? And so you're still in menopause. We're in menopause. Once we're in menopause, we're in it for life. But if we're able to replace, especially a hormone that is so vital in order to keep you to have a vital life, right? So that you don't just make the case, oh, I was just aging. I have all these aches and pains. My brain is not functioning as well, blah, blah, blah. But you want to be that person who is able to get up and go, think on your feet, be able to move forward with very important aspects of your life. Why not do that to the best of your ability with a little bit of help? And when I say a little bit of help, I'm talking about using that which your body has lost in order to keep you high functioning. I don't know. Seemed pretty good to me.
Eventually, it seemed pretty good to me too. I'll say that. And I want you to say this part, because I think this is something to put things relative to one another. Like the level of estrogen that is prescribed versus the level of hormones that are in, for example, birth control.
Right. And so for the most part, HRT, the level of estrogen that's in HRT is far less than what we would usually prescribe in a birth control.
And birth control, when people say, I'm on birth control, like people
say that all the time. I'm on the pill.
People don't bother thinking about, give me the pill and here we go. And so, and then here we are. And by the way, HRT is hormone replacement therapy, if we miss that. So then I started to take HRT, and miraculously, I live on the second floor, and I go up the stairs, and I go up the stairs every day, many, many times. And then all of a sudden I realize, hold on, I don't feel the pain in my knees when I walk up. And I'm sure that I didn't feel that pain for at least about a week or two. But when we're not in pain, we don't feel it. if that makes sense. You know what I mean? Like we're in a state of just doing what we need to do.
Doing.
I was just doing. But it just dawned on me like, hold on, something's different. Oh my God, the pain is gone. And that blew my mind. And then I started to think, okay, hold on.
What else is different?
What else is different? And then I said, oh my God, I am thinking all the time. And believe you me, I think all the time and not in a bad way. I'm just like a very curious person. And so those two things, I was like, okay. And then it was for me more, okay, how long is this going to last? Is it just, is it just because it got boosted a little and then it's going to wear off? Nope. Still don't have pain in my joints, still feel very sharp. I've had some bouts of feeling a little bit dizzy here and there when I started it, and I think my body was adapting to it. But after that, it was really good. And then one thing happened that I go quite in detail in episode 42, which is I started to have, now I know how to say it, a bleeding episode, not a period.
No, you did not have a period.
I did not have a period. But to my surprise, because I hadn't had a period in like 2-3 years because I was in menopause.
Yep.
And then all of a sudden, there's blood on my underwear. And I was like, what? And so, what is this?
What is this?
It's weird because at the same time, it's so familiar.
Yeah.
And at the same time, it's such a surprise. So very confused. And so then I went to the drugstore, got a pad, called Dr. Sophia and said, I don't know what's going on. And we had an episode where it was quite heavy. And then you told me the first thing to do was to get a blood test. What did you want to check with that?
I checked something called a CBC. I wanted to see if you were becoming anemic or anything, because you had described your bleeding as a heavy bleeding episode. So I wanted to see that. I wanted to see where your estrogen levels were, where your progesterone levels were. But the point of doing that was so that I can kind of see, is there something I needed to titrate? Do I need to go up a little bit on your estrogen, go down a little bit on your estrogen? Do I need to do the same with your progesterone, or what's happening there? Or is it just fine? And your body is kind of responding in a way that was like, I haven't seen this in a while. And, I remember what happens when I have these hormones in my body, and created this kind of scenario where you had the bleeding.
So there was no ovaries. There was no ovaries. There was no egg there that caused that.
No.
There was not like one last one that say, hello. You missed
me.
Yes.
Yeah, why not? I'm trying to get out. Yay. No.
There was none of that. So it basically created an environment that's similar to what happens when you were
getting your period. Mm-hmm. To some extent, I would say yes, because estrogen does do something called proliferative or proliferate.
So I was on estrogen and progesterone.
Yes.
I was not on testosterone because I didn't need it.
Just not where we are.
Okay.
Yeah.
Okay. Mm-hmm. So I was on both, and it created this environment and caused this bleeding, but you wanted to make sure, is there anything else going on or not?
Yes.
And it seemed to be okay. But then every, I would say maybe 15 days or so, I would have another bleeding episode that would resemble a period that would last for about 5 to 10 days. But my labs seemed okay. And then you said, well, maybe we need an ultrasound.
Yeah.
And what was the reasoning behind that?
Well, it was really to identify if you had what we call anatomic issues with the uterus. I wanted to look at the thickness of the lining of the uterus.
When you say that, the lining, meaning like how much the lining is, like the inside walls of the uterus?
That's a good way to put it.
Okay.
That's a good way to put it. It's the inside walls of the uterus, and those walls kind of touch each other, and it's to see if there's anything that is in between those walls. Is there anything whether that thing could be a growth of some sort, whether that growth is something called a polyp, whether that growth is something called a fibroid.
So inside the uterus.
Inside of the uterus against those walls that could be affecting or causing some of this bleeding. Because sometimes when you're on hormones, what happens is that it elucidates those things being there.
It brings it more to the forefront.
More to the forefront that maybe we otherwise would not have known about it. And so that's a part of why to do the ultrasound.
So then I went to do the ultrasound, and in my mind, an ultrasound is basically they're going to put gel on my tummy and take a device and go over it to see what's inside at the level of my uterus. And that was the case, but I did not know that they were going to insert like a plastic rod inside of my vagina also.
Okay. We usually call it a probe, but okay.
Yes. Well, it was like a long rod. So I'm just going to call it that. And I was like, what? Okay. I like to be like mentally prepared for anything, so,
No, this is a good point. I think it's important to actually describe. So when a woman is given a prescription or a referral to have a pelvic ultrasound, that pelvic ultrasound can sometimes incorporate what's known as a transvaginal ultrasound. So I'm happy that you're bringing this point up because, a lot of times women are surprised, just like you were. So the point of it is they use the one probe that's on the abdomen or on your belly to see one view. And then sometimes it's not enough or they can't see everything that they need to see with that abdominal probe. And so they have to use what's called the vaginal probe in order to better analyze things. Perhaps sometimes it's to see better your ovaries. Sometimes it's a better way to see the lining, for example, or if there are things about the architecture of the uterus that they were not able to see through the abdomen, then they can see it through the vagina.
I just want to pause. I like the architecture of the uterus. I like that. I never thought of it because it's true. It's a piece of architecture. Okay.
Well, there are different parts to it.
Yes, there are.
So the concept here is to see if we can, bring to the forefront what is happening and if it's something that's structural. And in doing that, we're able to see that in your particular case, you were experiencing what we call a thickness or a thickening of the lining.
So by the way, the moment that we're talking about ultrasound, now this is officially the 4th installment of Touseef on HRT because that wasn't in the previous one. So everybody knows all these episodes, if not for anything for myself. So did the ultrasound. And then Dr. Sophia looked at it and basically you said, yes, there is thickening, but I don't think there should be a lot of issues with that. So why don't we continue for a little bit longer on the same dose and maybe your body just needs to level off a little more. I was still having the bleeding. And then you said, okay, well, now maybe the next step to do is actually to have a biopsy. Is that what it is?
So we went to try to do something called a hysteroscopy. That's why
hysteroscopy.
Hysteroscopy.
Yeah.
A big word that really means to take a look inside of the uterus with a camera in order to clearly identify what could be on the inside of the uterus.
So maybe something that couldn't have been seen or detected clearly from the ultrasound?
That's correct.
Okay.
That's correct. And then also at that same time to also collect some of the cells through what's known as an endometrial biopsy.
Which means?
To collect the cells of the endometrium. So the endometrium meaning the lining.
Inside the uterus.
Inside of the uterus.
Yeah.
And then biopsy, taking a sample that we can then send to pathology in order to identify what is there.
And so the first sort of approach that you wanted to take to see if we could literally figure out a way for you to insert an instrument to get to the uterus while me being sort of in a more lax state. Would you say that's the case?
The first step in it is to see if we are able to accomplish this through an office procedure.
Okay.
Right? Most women who need a biopsy tend to have these things done in the office. And It can be a very painful procedure. So the goal here is to try to what we call pre-medicate, so that women can go through it with less discomfort, less pain as best as we can. So in your case, I gave you some medications in order to help soften the cervix first that you would take before you come to your visit. I also gave you some medications that would help to more relax the uterus, or at least be counteractive towards the crampiness that one can feel on going through the cervix in order to get inside of the uterus. And I also gave you some medications that you would take at the moment of your visit. So about 20 to 30 minutes before, in order to help with just relaxation during the visit. With all those things in place, then it makes the procedure a lot faster. And it's interesting because it's a procedure that doesn't take too much time necessarily, but like I said, it can be one that can be very painful. And so doing those, kind of taking those steps, does make it more possible to be done in the office.
So, based on everything that Sophia said, so now I go into the office and I'm mentally prepared. She's told me all this information. So, okay, let's go. And then she starts the procedure. You start by first putting a speculum, which is usually what you would do for a pap smear, for example,
Yes.
Right. So you put in the speculum that opens up the walls of the vagina. And then you need to go through the cervix.
Yes.
And the opening is just at the center, right? And you need to like go through like the center of it.
Yes.
And so that became more of a challenge than what we had expected.
Yes.
And we tried for a while. I tried to relax my bum and also just what's it called?
Your pelvic floor.
Thank you very much. Yes, I was really trying to relax. And wouldn't you say I did a good job eventually?
I think you did a great job.
Yes. And then eventually, like, when you would like move something or then I would contract because that's just a natural reflex. And there was a point when the speculum literally shot out.
Yes, literally.
So all that to say, I'm very happy
that you have a strong pelvic floor.
I have a strong pelvic floor. That was so exciting to know. And that all my gym workouts are right on the money. So that was a really good point in the procedure. And so finally you decided we're going to stop because you weren't able to go through the cervix.
Yes. And I mean, the goal here is not to torture you, right? So if it's not working, it's not working. We stop.
Right. Because you tried different things.
I tried a lot of different things.
I mean, I refused to look what you were doing, but I know I heard clicking. I saw your arms going left and right. I'm just like, I'm just going to
stay zen.
I don't think it was zen. But I'm just going to relax my pelvic floor. That's all I'm going to do.
That's what you were trying to do anyway.
That's what I do. Yes.
Yeah. I would say that there has to always come a point in time where you're like, okay, this is just not going to happen this way. And the moment where I'm like, I still need to do what's safest for you. So even though I would love to have this information at this moment, but I also had to be like, okay, it's just not happening. For whatever reason, there's some type of like anatomical thing that's happening that's making it that I can't gain entry into your uterus, and I'm not going to force it. I don't want to put you through more pain than you need to. I don't want to do something that's going to be harmful. And it's to keep you safe. And also recognizing that there's another way. We have options. We have options. If I can't do it in the office, it's okay. And that's basically what we had to decide.
So then we decide, okay, let's go to the next thing. And the reason why we're talking about all this is that a lot of people are talking about HRT, and it's to recognize that, yes, it has so many benefits. And also there is a phase where you're trying to balance it right, or to certain things come up that you need to address. Would you say it?
Yeah, the
that
real
way?
reason of having this conversation, is because we're talking about Touseef HRT.
Yes.
And we want to bring the reality of people on HRT. This is not just, it's just this magic, right? I'm thankful and I'm happy that you feel great while you're on your HRT, but I think we're doing a disservice if we don't acknowledge the fact that everybody on HRT is not just going through this like smooth sailing. I think you have clear benefits of being on your HRT, but if you are among those people who have some of these side effects in the sense that you experience a bleeding episode, let's say, that can be very jarring and very scary. And if you don't know that it's a possibility, or if you don't know what's next, what does it even mean? I think it can be a reason for a lot of concern and alarm in the person that it happens to. And so I just wanted us to be able to be honest, because I see all the social media on HRT, 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 and I'm a big proponent of HRT. I even with your bleeding, I'm like, okay, and this doesn't change the fact that you still need to be on this HRT. We just need to get to the other side of the bleeding. But I don't think that people recognize that everybody doesn't go through it the same way. That's one. The other thing I like to point out is that it's very similar to like a 25-year-old who's on birth control, who may have breakthrough bleeding, or who has like weird things that happen to them while they're on the pill, while they try to figure out, well, maybe this pill's not for me. I need to switch and be on this pill, or this formulation versus another formulation. There's still a kind of like a trial period, or a period in which we have to get your body into some type of balance. And for some people, that means in terms of symptoms, whether those symptoms go away, or whether there are symptoms, new symptoms that arise, or what have you. For some women, progesterone is it's great when we replace their progesterone. They get to sleep better as one of the benefits of being on progesterone. But other women, progesterone just makes them have even more anxiety, or more paranoia, or more emotional lability, and then we have to figure out a different way of helping them to protect their uterus. And maybe it's not with an oral version of the progesterone. So it's like there's so many different nuances with how we are treating women and managing their symptoms and managing potential secondary effects, and still keeping them happy, while they're on their HRT journey. So that is the real reason why I'm happy that we're having this conversation, because I don't want it to feel like all we do is talk about this one side, when there are some women, and this doesn't happen to everybody. The bleeding doesn't happen to everybody. Like, really, I have so many women who are on HRT who have zero like side effects, right? They just feel the benefits and they feel great, and they don't have any skin issues. They don't have any bleeding issues. They don't have any bloating issues. And then I have people like you who may experience a bleeding issue. And then we have to do some investigations, because at the end of the day, yes, I know I put you on a medication, and I know that that medication can cause some of these things, but I need to be sure.
You need to be sure that
it's just the way of the medication. And then therefore I can then make adjustments, right? Once I know that there's no other issue that's happening in the background that's actually causing the bleeding, right? It could be that you had a fibroid. It could be that you have a polyp. It could be, all these things are totally possible and easy to manage, actually, and treat, and so that's where this part of the conversation becomes so important. So that way women don't feel so scared should they have an issue with their HRT. We're not saying that HRT there's only one way. Women have options. And not only that, but just like if you get started, let's say someone who has to be on a blood pressure medication, there's sometimes some calibration that needs to happen before you're in a good, really, really good place. Same thing.
We decided then, since we couldn't do it an in-office procedure, then I had to come back and actually have what we call a minor surgery.
Right. So a very similar procedure, but done in the operating room, where we gave you like sleepy medication through the anesthesia, where you're a lot more relaxed. And it allowed me to have a lot more access and to be able to do what I needed to do in terms of being able to look inside of your uterus in a more safe way. Because given the fact that your body becomes so relaxed under anesthesia, then I was able to see that, hey, well, we're going to share this, right? Your cervix has a little twist to it. You know, it's not just straight. And it was something that was hard to elucidate or for me to know while in the office, which way your cervix had a little bit more of a tortuous, it has a turn to it, a little curvature.
So you can't go straight.
So you can't go straight. And going straight would have been disastrous. So in the operating room, when you are fully relaxed, when I can now use other instruments that can help me to be able to see, literally guide me through your canal, and then I'm able to then get to where I need to safely in order to be able to see. And also to be able to collect the biopsy that I wanted to be able to do for you. And so that was the purpose of taking you, well, not first of all, stopping in the office because it just wasn't possible. I didn't want to cause you any harm or make the procedure traumatic for both of us at that point, right? I don't want to make it traumatic for you in the sense of increasing or causing you pain. And then for me to cause any harm, that's going to be like, oh my gosh, what have I done, right? Like I don't want to have complications that I can avoid.
So then we did that, and you were able to get the cells that you needed.
Yes. And the video, like in terms of really looking, I could see inside
Like, this
of
is what
your
I mean.
uterus.
She knows me inside out. So wild. And then thankfully, everything is fine. The tests came out normal.
Yes.
So, I mean, the good news, I mean, I'm a relentless optimist. So the good news is all of this is my uterus is fine. So we know there's
uterus is totally fine.
There's no fibroids. There's no nothing. Everything's fine.
Yeah, you had a little polypoid tissue, but that's benign, completely benign. So one of the major things to always take into account here is to make sure that there's no abnormal cells or cells that could be considered cancerous cells.
That could be the cause of the bleeding.
That could be the cause of bleeding. Exactly. And so we want to, as much as we can, always eliminate that as a potential for why you could be having bleeding. And we tried so many ways in which to manage the bleeding before we're getting to that point. There's at least a 6-month period where your body is just adjusting. But once we kind of got past that point and you were still and we try to do the adjusting and it's not working, then this was the next step. And now we're on to the next step.
And the next step, now that we have basically done all those tests and sort of checked everything and say, okay, everything's fine. Now we're going back to actually seeing, all right, so how do we balance?
Right.
How do we balance
adjust?
it?
Exactly. So now we can go back to the drawing board with a much clearer picture and saying, okay, now all I really need to do maybe is just increase your estrogen a little bit, or maybe I need to give you a different formulation or a different way that you take it in order to really help you to the point where you're not having these bleeding episodes that you have.
So the journey continues.
Yes.
The journey continues. The HRT journey continues. I mean, I will say that even though, you know, I went through all of these different aspects and these procedures and figuring stuff out, I'm still very happy with HRT. And I'm not trying to like tell people to be on it. I'm just speaking for myself. I just see how much it's given me a better quality of life. And that's what I want in my 50s. And so I'm just happy that everything is okay and we just keep trucking along until I have no more bleeding and no more issues. And if that is an effect of having this, I'm okay dealing with it until we can find the end solution. Yes.
Yes. So, and then on my perspective, from my perspective, I want to reassure you that we'll find the solution. And at the end of the day, I want women to feel confident in their particular journey. And I want them to be informed. And I want them to have information without it being like an alarmist type of way of, oh my God, I saw blood, so therefore something's definitely wrong. This HRT is the worst or something like that. Because it's like to remind you, wait a minute, what about your brain fog? Wait a minute, what about what this is doing for your bones or your heart? Wait a minute, let's, and you have an opportunity to make the decision that's best for you. And I just want, in having this more kind of nuanced conversation about HRT, that we bring the full scope. It's not a one-trick pony. There are some curveballs sometimes. There are some challenges with it. There are some points in which we have to make adjustments. It certainly doesn't make it bad. It certainly doesn't take it off the table because you're going through certain different aspects. But it's good to know that those aspects can exist, can happen. And for the most part, for most of my patients who do have any of these challenges, they, like you, say, well, okay, what are we going to do to fix it? Because I'm not coming off my HRT.
Mm-hmm.
And that's really what it boils down to. And lastly, it's to understand that HRT is not the whole picture. There's so much more that women still need to be doing along with their HRT, which I think you do a great job of this, which is how you're eating, your nutrition, your exercise, your lifestyle. Like it's a whole lifestyle, in this quote unquote menopause phase of life, because we're in this stage. Like I said, once we're in it, you're in it. You're in it forever. You're menopausal at 80. You're menopausal at 90. This is not like, oh, I just got into menopause at 50 and that's it.
Mm-hmm.
No, that's it. Meaning we're in this for the rest of our lives. We have to find a way to manage this part and give us a life that we want to live, a life that is a very vital kind of life. And HRT can be a part of that picture, but it's not the only aspect. I hate talking about HRT or menopause and menopausal symptoms or where we are when we're in this second act of life without bringing in the piece of, well, how are we eating, and making sure that that's also a part of the discussion. How do we move our body? And that's also a part of the discussion. How do we treat our brain in terms of longevity, whether it's talking to friends, being social, meditation, journaling,
Keeping it active
and also keeping it calm.
Mm-hmm.
So I guess the bottom line for me is embracing the whole aspect of being in this menopause phase. All of it. There's ups, there's downs, there's things we need to balance, but you're going to be on the other side.
And it's a great side. I mean, I'm very happy to be on this side. The 50s are fabulous. Fabulous 50s.
Love that for you, girl.
Yes,
love that. Love it. Love it. Love it.
So I think we can continue. We'll have another installment. Yes. Once we find the right balance, and then what does that look like? I just want to come back on one thing that you said that I think it's important. I was also concerned when I first saw that I was bleeding, because I was just like, what happened? Am I hemorrhaging? Am I doing, like, what's happening? It didn't click to me that that's part of how the lining is, like the way you explained it. I don't know these things. And I think our natural reaction when we see blood is we panic.
Yeah. I can definitely agree that most people panic.
Right. And so I think it's a natural reaction, but I think this is why this conversation is so important, is to educate people and actually say, no, actually, this is part. This can be part of the course. This can be part. This
can be part of the course
of this journey of trying to figure out the right balance.
Yes, yes. And then I do have occasionally some of my patients that'll be like, "Oh, does this mean I can have a baby now?" Oh, can I get pregnant? Do I need birth control too? And I'm like, no. I mean, we're on HRT so that we can feel young. I understand, but we're not that young.
Yeah. No, we're always young.
Definitely at heart. There's
yes,
no
everything
question.
at heart.
I am
Yes.
perpetually 25.
But we evolve.
But we evolve. Yes. Oh, Dr. Sophia audience, we are so happy to have you here. We just always invite you to embrace your body, embrace yourself with the ups and downs of menopause and HRT. Bye for now.
Bye.
This is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Until next time, embrace your body, embrace yourself.